So our next speaker is Justin Shear. Justin is another UCSF graduate. Justin is probably most published residents at all time. I think he published 200 papers during his residency, if not more. So now, besides he's been a phenomenal surgeon, he's also a phenomenal researcher. So he's going to give us talk about thoracic shape, kyphosis, defining normal and abnormal before and after thoracolumbar deformity surgery.
Thanks for that intro, and thanks to the course directors for allowing me to present. Did we lose the screen? I need a step. Okay, I can just go like this. All right, so I've been asked to talk about thoracic kyphosis, which is a tricky topic, right? Because it's a moving target, as we've already heard about. So being new to this, right, I wasn't sure kind of what this even means, so I went to literature, which we'll walk through. No disclosures. All right, so it goes without saying, right, that thoracic kyphosis is integral to standing balance, as we've heard about, with Mike Kelly's paper, and needs to be incorporated into our decision-making to treat these patients, right? So it can either be the primary driver of the deformity, or it can be a compensation mechanism, right, for some other deformity that's going on. Either way, if you're correcting any deformity in the spine, you're going to be involving the thoracic kyphosis in some way or form. There could be reciprocal changes, and there could be, so we need to know what normal and abnormal is, which, as you'll see, is sort of up in the air. Yeah, I don't think the mouse is working. There we go. All right, so starting from the beginning. So this actually has been studied for a long time, right? Since 1960s, actually. Rofe here defined normal thoracic kyphosis as 20 to 40 degrees. And that sort of stuck around for quite a while. And then Fawn in 1980, as you can see there, looked at 450 chest x-rays that were normal according to a radiologist. These are not, spine x-rays, they're just chest x-rays. And again, agreed, 20 to 40 degrees was defined as normal. You can see the tables there, male and female stratified. The younger patients had around 20 degrees, and the older ones had around 40. Now, it wasn't until 2021, after this has been studied pretty extensively, that a large meta-analysis was done from 7 databases, including the Spine Journal, from their inceptions to 2020. And they pulled out 34 studies that only focused on normal thoracic kyphosis to try and make sense of this. And they found that 20 to 60 degrees seemed to be what's normal when you pool all the patients together. But this sort of challenged the idea that 40 degrees was normal, because 35% of them were above 50 degrees and 65% were actually above this 40-degree threshold that they found in the 80s, right? So they also looked at age, gender, and ethnicity differences. And of course, we know thoracic kyphosis increases with age, and they have it broken down there. For the younger patients, it was basically 30 to 40 degrees, up to 55 degrees, and more for the older patients. No differences in gender, but the Europeans and North Americans did have slightly greater kyphosis than the Asian cohorts. Then fast forward a little more to the mean study, which we've already sort of talked about a little bit, but focusing on the thoracic component of the study. Right, there's 468 patients, sort of the largest to date of normal spinal alignment in asymptomatic volunteers. And what they found was a mean of 37 degrees, plus or minus 11. And there's the confidence interval there. Again, they didn't find any gender differences, but TK did increase with age, and lumbar lordosis did not, which is kind of interesting. And at least in this study, it did not correlate with PI. What happens is as the thoracic kyphosis becomes more of a C, right, you get more of it, they compensate with increased cervical lordosis, hip and knee flexion, and increased pelvic tilt. Right. So then, we've already talked about this at length. Mike Kelly did a great job, but how does thoracic kyphosis fit into this, right? So looking at this axis can help with that for alignment targets. Sort of moving away from the degrees that people have been studying, like what's a normal degree of thoracic kyphosis, and more, how does it fit into the overall spine? We've already seen this figure a few times, but basically looking at 320 volunteers, C2, T4, and L1 pelvic angles. And they're all related, of course, but here's, I think, one of the most important things, right, is that T4, PA, and L1 align, right? We want them to be pretty much the same. And that will allow the thoracic kyphosis to be sort of in harmony, if you will, with the lumbar spine and the pelvic incidence. So for high or low PIs, right, this holds, which is nice, right? So per the paper, this is kind of the equations that they came up with, and the mismatch is about 0, which we've already heard. Now, abnormal thoracic kyphosis, right? What is that? So it's either hypo or hyperkyphosis, and it's pretty much anything outside of that range that we've defined as 20 to 60 degrees roughly. But in the literature, most will say less than 30 degrees, some less than 20 for hypokyphosis, right? And it can be reduced in scoliosis, as you can see on the patient on the right. I think most people would agree that's hypokyphosis, or compensation for the patient on the left, right? Because of the severe flat back. Hyperkyphosis is a bit more varied, actually. Anywhere from greater than 40 degrees to greater than 70 degrees. And we've heard about Sherman's just now, kyphoscoliosis, that's the patient on the right there, right? No one would argue that that's not hyperkyphosis. And of course, PJK, the bane of our existence, right, would be hyperkyphosis. But then of course you can have, compression fractures, post-traumatic, et cetera, leading to this that may or may not be treated. So how about after surgery? What's normal post-op thoracic kyphosis? And this is where it gets tricky because the studies I've shown were patients that were asymptomatic. They were normal patients, right? The patients we're treating are not normal, right? They have varying degrees of degeneration. They tend to be elderly, and they have a deformity. So by definition, their spine is not normal. Well, what's normal to them? Well, it depends, right? As we've seen on the shape of the spine, their anatomy, what the goals of surgery are, right? Just like Mike Kelly said, maybe we're okay with some hyperkyphosis as long as the patient is within the cone of economy. As long as they're standing upright, that's okay, right? So that's why he wants to push us away from this degree notion and look at more of the spine as a whole with the angles. Things need to be in proportion, right? The two arcs, as we've been talking about. And then when you're planning your surgery, as we know, if you're going to the upper thoracic for UIB, you obviously have more control over the thoracic kyphosis and know how you want it to be versus a lower thoracic UIB. So those are things we'll discuss briefly. So how does this hold up? How does the T4 L1 hip access hold up for patients undergoing, thoracolumbar deformity correction with UIB T1 to 5 into the pelvis? So ISSG did this nice study, 247 patients looking at mechanical failures and seeing who was mashed, who wasn't. And basically what they found was for T4 L1 mismatch, if it's -3 to 1 degree, you kind of minimize, right, the complications. So this isn't looking at an absolute value of thoracic kyphosis, right? This is just an angle relative to the pelvic incidence in the L1 PA, right? Which is very different thinking than what's been going on since the 60s. We've already seen this figure, but I think it's an outstanding figure that really emphasizes this point, right? So less mechanical failures if you can line this up. Now, what happens to the thoracic spine in thoracolumbar deformity surgery, specifically the spine and the shape? So this was a nice study by ISSG looking at 329 patients fused from T5 to L1, no prior thoracic fusions. And what they looked at was before and after surgery, the shape of the thoracic spine, and they categorized them based on hypo, normal, and hyperthoracic kyphosis. It was just the mean of the cohort plus or minus 1 standard deviation, or 1.5 standard deviations. That's why you have those numbers there of less than 30 degrees for hypo, and hyper is greater than 70 degrees, at least in this cohort. Here's just the median interquartile range. So it's around 40 degrees for all of them. And then the hypers were around 75, 45, and 18.6 for hypo. But here's the figure I think that sums up the entire paper. The translucent spine is the pre-op spine. The more darker spine is the post-op spine. And they broke it down by hypo, normal, and hyper beforehand. So what you can see here, for the hypothoracic kyphosis patients, you have a large increase in kyphosis proximal, right? T1 to 11. Not much change below. Normal, it adjusts, right? So the proximal change in the thoracic kyphosis is smaller, but it's there. And then you have a flattening of the distal kyphosis. And then for the the hyper patients, you have very little change in the thoracic, but a lot of flattening in the distal region. Right? So these are considerations for surgery planning. And here's just some examples from the paper. So on the left, hypo to hypo, right, it stayed the same, whereas on the right, they went from hypokyphotic to a normal kyphosis based on their definition of 30 to 70 degrees. Here's hyper to hyper, so the patient stayed hyperkyphotic afterwards. And then hyper to normal is more like a Schuman's case that we just discussed. And then normal stayed normal, and then you can always make them hyper, right, as well. So there's a lot of control over the spine when you're actually including the thoracic spine in your constructs. Now, things start to change when your UIV is in the lower thoracic spine, right? Because we're sort of relying on how the patient is going to stand. So how do we quantify that? How do we know what normal thoracic kyphosis is after these types of surgeries? Well, it's very difficult. This was a nice paper by Themi looking at 219 patients in the ISSG, UIV in the lower thoracic spine to the pelvis. And they basically looked at the patients who had a reciprocal thoracic kyphosis change, 53% of them did, or those that maintained it, right? So the other 47%. And they looked at the unfused segments and how they changed with and without PJK. And basically, patients that are compensating, right, for the thoracolumbar deformity are having some hypokyphosis. And the way they measured that was the PI minus 20 degrees. And this is from an equation that Schwab and colleagues came up with for ideal lumbar lordosis. So here's just an example from the paper of the kind of groups that they made, right? So no change, and then in the middle, you had reciprocal changes, but you didn't develop PJK. And on the right, you had reciprocal changes with PJK. And what they found was the RK, right, the reciprocal kyphosis group, had a greater change in the unfused segments, which makes sense. They had a greater PJK angle, and they had more pre-op thoracic compensation by almost 10 degrees. So the presence of preoperative thoracic compensation is a risk factor for PJK, up to 66%, right, over 19. So we're still trying to figure out how much it's going to move. And there's some papers on flexibility and things like that, which are evolving. So in conclusion, normal pre-op TK is still being figured out, right? There is a large range, kind of depends on the anatomy and the patient, but generally 40 plus or minus 10 degrees seems to be reasonable. But as we just discussed, we're trying to get away from the degrees and go more towards the pelvic angles because it can help with planning. It can also help with mitigating mechanical failure. Abnormal pre-op thoracic kyphosis, we discussed, right, hypo and hyper with the numbers there. Post-op thoracic kyphosis, same thing. The pelvic angles seem to show some promise, especially if the UIV is in the upper thoracic spine. If not, if your patient's having significant thoracic hypokyphosis from compensation, they're at a much higher rate of having PJK. And all this to say, like Mike Kelly said earlier, TK and LL is meaningless, maybe. But we're still trying to figure it out. A lot of studies still need to be done to find out what's best for each patient. Thank you.
Questions for Justin? So in terms of planning the deformity surgeries, when you talk about the reciprocal changes, I think there was a common a couple of years ago, maybe 5 years ago, we kind of approached the thoracic spine. If the patients are able to hyperextend in their flat back deformities, tendency is to stop at T10. If they are kyphosing and then more tendency to go to T4. Is that still apply? Is that what your study showed? Similarly, pre-op reciprocal changes also affect the post-op reciprocal changes?
Yeah, it seems like the opposite we should be doing now, right? So if they're having a lot of a lot of pre-op thoracic compensation from flat back or something, then maybe we should be actually extending it up to the upper thoracic because they have a much higher rate of PJK because they're then relaxing back down. That's sort of what I took away from it.
I think the idea was at the time was more because of they have extensor muscles are stronger, that they are able to compensate and then they can actually use the extensor muscles and less likely to get PJK. But it was all anecdotal. It wasn't based on the data. So you're saying the opposite basically. If they are compensating, then more likely to go T4.
Yeah.
I have a question about that. So if somebody's compensating, that means their muscles are working
Yeah, it's a great question, and for sake of time, I did not include those studies. And part of the reason why is there's two decent ones, if you will, with good numbers that are 100% opposite of each other. One says the more stiff spine is higher PGK rate. One says more flexible spine is higher PGK rate. And they both have their reasons for that. So I actually don't know, and there's actually not much studying on that. And the way they measure them was supine x-rays. You would think, yeah, but we don't know.
Seems like we need more research. I think the thoracic spine is not studied as much as the lumbar spine currently. I think we are going to move forward to study more thoracic spine. So our next speaker is, thank you, Justin.